the context about death, I think, is so much of it is to do with fear. And studies like this show that so many people are terrified about death. And it seems to me that so often it's fear that drives a lot of the public debate and the controversies in the highly contested areas. And as we all know, there have been a whole series of tragic stories that have hit the headlines. I just chose one or two at random. This is the story of Jeff Spector, who was a very well-known self-made businessman, apparently, quite well-known in his local area. And he was diagnosed with an inoperable tumour on the spine, which was about to press on the spinal cord, and he was told that was really not much that could be done for it, and that he was going to end up paralysed and probably incontinent. And Jeff Spector said, well, absolutely no way, Jose, that's not me. And so he called together a celebration meal, and apparently this photograph was taken. He called his family and friends. They had a slap-up meal together, and at the meal he told them that the following morning he was going to take a flight to Dignitas Clinic in Switzerland, where he was going to commit suicide. And they tried to talk him out of it, but he said, it's my least worst option. I don't want to be dependent. I don't want to have other people caring for me. And so, sure enough, that's what he did. And he went to Switzerland and took a lethal dose of barbiturates and died. Sir Edward Downes and his wife and another, he was just frail. I think she had cancer, and they'd had a suicide pact that they would die together, and they went to Switzerland and they died hand in hand. And the newspaper coverage again was pretty positive, saying, what noble people that they and their family were there, and they had a final celebration meal, and then they died hands in hands. And why on earth did they have to travel to Switzerland? Why couldn't this be made available here in the UK? This is Daniel James, a very promising young rugby player, involved in an accident, paralysed from the spine downwards, from the shoulders downwards, and he became deeply depressed. He was a very young, sporty guy, and then he tried to persuade his parents. They tried to jolly him along. They bought him gym equipment. They encouraged him to make the most of his life. But then he said to them, if you really love me, you'd help me to kill myself. And they tried to talk him out of it, but eventually they agreed, and they took him to Switzerland, and again he died. And the newspaper coverage, by and large, very positive. What noble parents. They didn't want to put their own interests first. They wanted to do what was best for their son. And why on earth did they have to go all the way to Switzerland? Tony Nicholson with locked-in syndrome, who became deeply depressed and said that if he had any control over his body, he would have committed suicide. But since he was completely locked in, he couldn't commit suicide. And he went to the High Court, and ultimately, I think, all the way to the Supreme Court, arguing that it was his human right to be killed by a doctor because he wasn't able to kill himself, and that everybody else was able to kill themselves. And the case hung by a thread, but in the end, the Supreme Court said this is a matter for the legislature, for Parliament, and we can't approve of this act. And so apparently Tony Nicholson was deeply upset when he got the news of the judgment, and he went into a hunger strike, I think refused food and fluids, and died a few days later. I came across this story, which it was an obituary, and at first glance it just reads like a normal obituary. The founder and president of Homeshare International, Nan Maitland, died on the 1st of March. Homeshare was a central concern for the last 25 years of Nan's life. Her vision, energy and inspiration will be missed by all of us around the world who are captured by her warm personality and compelling charm. But when Nan Maitland died, all her friends received a letter, and this is the wording of the letter. By the time you read this, with the help of friends at the end and the good Swiss, I will have gone to sleep never to wake. For some time my life has consisted of more pain than pleasure, and over the next months and years the pain will be more and the pleasure less. I have a great feeling of relief that I will have no further need to struggle through each day in dread of what further horrors may lie in wait. For many years I have feared the long period of decline, sometimes called prolonged dwindling, that so many people unfortunately experience before they die. Please be happy for me that I've been able to escape from this, for me, unbearable future. I've had a wonderful life and the great good fortune to die at a time of my choosing and in the good company of two fate, that's friends at the end, colleagues. With my death on March the 1st, I feel I am fully accepting the concept of old age rational suicide, which I've been pleased to promote as a founder member of the Society for Old Age Rational Suicide in the past 15 months. So it's interesting that this sort of promotion and rehabilitation of the fact that suicide can actually be a noble and a rational and a responsible way to die is something, seems to be an idea that is gaining currency. But of course there are many other factors in this debate, and one of them is dementia and the rising incidence. And because Alzheimer's disease and dementia generally is an age-related illness, the projections, because as the population increases in age, the projections are really quite startling. This is just figures for the UK. In 2012, 800,000 people with dementia. 2021, 1 million. 2051, 1.7 million. And so as health planners and other people sort of look into the future and they say, how on earth are we going to cope? How are we going to cope with this massive epidemic of people with dementia and with what the care needs? And in private, a significant number of people start to think, you know, if we could find a way of rehabilitating the altruistic suicide, you know, that at some point you do the decent thing, you know, you say, I've had my life, and then you do the responsible thing, which is to take your life. Wouldn't that be a solution? Now, for most people, those thoughts remain only in private, but Mary Warnock, well-known moral philosopher, actually voiced these thoughts. And some years ago she said this: if you're demented, you're wasting people's lives, your family's lives, and you're wasting the resources of the National Health Service. I'm absolutely fully in agreement with the argument that if pain is insufferable, then someone should be given help to die. But I feel there's a wider argument that if somebody absolutely desperately wants to die because they're a burden to their family or to the state, then I think they too should be allowed to die. Now, perhaps not surprisingly, there was a lot of pushback with those comments. That people from the Alzheimer's Society and various other people working with demented people said this was outrageous and unacceptable and all the rest. But I've heard people in private, including medics, saying these kind of things before. So I think she's merely voicing what remains thought, but socially unacceptable at present, the idea that that dementia might, that suicide, a rational, responsible, altruistic suicide, might actually provide a solution. But of course, on the one hand, you've got people saying that maybe suicide is an option, and then you have to, of course, put that in the context of the, I'm afraid, often appalling way in which we in the UK care for the elderly, and the very bad situation in which so many elderly people find themselves. And of course you can't differentiate these two, that if on the one hand you're promoting suicide and at the same time recognising that care is very, very bad and inadequate, there's a disconnect there. But I think we can recognise there are a number of social pressures then, increasing demand for some kind of medical killing, either euthanasia or assisted suicide, the ageing population, the rise in chronic disability, rising healthcare costs at the end of life. So people calculate the entire lifetime healthcare costs. It turns out that some extraordinary proportion of your lifetime healthcare costs are spent in the last year of life, and sometimes just in the last 6 weeks of life when you get admitted to ITU and have, you know, massive futile interventions. And so this is another reason why people are saying, I don't want to end like that. I don't want to end in an ITU with tubes coming out of every orifice. And maybe having the option of some kind of assisted suicide would be beneficial. There's family breakup, increasing social isolation. The statistics about the number of elderly people living in an institution who have a visit less than once every 3 months from a friend or family relative. I mean, it's appalling the number of isolated elderly people there are. And then wouldn't suicide be preferable to that kind of existence, just eking out your day in an institution abandoned? So in Holland, euthanasia for cancer is pretty well routine. It's pretty well normal and accepted. What is happening now is that euthanasia, some forms of medical killing, are being widened to other population groups, and in particular they include people with psychiatric illnesses, including things like untreatable depression, schizophrenia, anorexia nervosa, and so on, and also to people with early dementia who are still who still have capacity to agree to be killed before the disease becomes too advanced. And the figures have shown a steady year-on-year rise in those categories, including for psychiatric patients. And also, as many of us have heard, that in Holland, euthanasia has been extended to children below 12, same is happening in Belgium. And assisted suicide legislation is steadily going across the North American continent as well. So a number of states in the US have now passed bills which provide some kind of medically assisted suicide. California is the latest in the US, and the Canadian Supreme Court has also passed assisted suicide legislation and said it was up to the states in Canada to come forward with mechanisms by which assisted suicide could actually carry out. So it does seem as though this trend, including making it within the medical arena, that some forms of medical killing, is something that is slowly spreading across the world. And in various studies in the UK, up to 80% of the population have said that they are in favour of a change in the law. Now, how much in those kind of studies the general public actually understand what they are agreeing to, as so often happens in these kind of surveys, if you change the wording slightly, you can get very different responses. And I think that if your average person in the public is asked the question, do you think that people should be helped to die? I think, or assisted in dying, then I think most people would say, well, of course I do. But if you actually explain what is being, in words of one syllable, what is being proposed, they might come to a rather different conclusion. But nonetheless, it is clear that there is apparently a large majority within the population who are saying that the current situation is unacceptable and that we want to have some means of controlling the end of life. And I think, as I said at the beginning, so much of this is driven by fear, and it's worth just thinking about what the fears are. And I think some of the fears are just to do with pain and suffering. So it's interesting that in modern society, it seems that pretty well we've lost the belief that any kind of discomfort, suffering or pain could have any beneficial or positive value. It is seen as something that is entirely negative, entirely destructive, and entirely to be obliterated. So anesthesia becomes the ultimate good. Just put me out, doc. I don't want to know anything about it. I just want to be put out. And it's interesting, the one area where that doesn't apply is when we come to sport. Because when it comes to sport, everybody knows no pain, no gain. So it seems that in the sporting world, everybody knows that you have to suffer agonies if you're going to be an Olympic athlete. But that only applies to sport. In the rest of life, pain and suffering is seen as something that's entirely negative and destructive and to be avoided at all costs. But it's not just pain. There is a great fear of indignity, the idea of ending up in a intensive care unit with tubes coming out of every orifice and having your bottom wiped like a child. This is just seen as something that is horrific and undignified, and I'd much rather die in control of my life. There was a poster from the Dutch pro-euthanasia campaign, and it showed this chap in a three-piece suit getting down into a coffin and lying down in his three-piece suit, and underneath it said, "Everybody has the right to die like a gentleman." And it's that kind of idea that you are dying like a gentleman in total control and not suffering the indignity of medical care and so on. And then the third fear, and in some way I think the deepest fear of all, is fear of dependence. So for modern people, this idea that I am in total control of my life, that I choose, I'm autonomous, I lead my own life, and what I don't want to do is to end up my life dependent on others. And I hear a lot of people coming from a Christian background who I think ought to know better say exactly the same kind of thing. I hear them saying, I'm very happy to care for other people, I'm very happy to look after others, but if I ever become a burden to other people, I'm going to say to God, thank you very much, I've had my life, I'm going to go to heaven now, goodbye. And it's, you know, that view that being a burden on others is a terrible, undignified, subhuman kind of condition, I think is very common. And autonomy, my right to choose, my right to live my life, becomes the ideal way. And a lot of this philosophically stems back to the Enlightenment, and particularly John Stuart Mill, very influential UK philosopher of the 19th century. The only purpose for which power can be rightfully exercised over any member of a civilized community against his will is to prevent harm to others. Over himself, over his body and mind, the individual is sovereign. It's interesting that at the time that Mill was writing, political philosophy was developing the idea of the nation state, the idea of a sovereign state. And within the sovereign state, within the borders of a sovereign state, the sovereign himself, or the sovereign power, had total control over all the laws. What happened outside the boundaries of the state was a matter for international treaty. But within the boundary of the nation state, the laws were simply up to the sovereign. And that idea of the sovereign state is still around, and interestingly, it's still a lot of the debate about Brexit is about the idea that Britain should recapture its rights as a sovereign state. But now I think what John Stuart Mill is doing is that he's applying the same kind of idea to the human person. And he's saying that within the borders of your body, you are sovereign and you make your own rules. And nobody outside has the right to say what your rules are. So it's the same idea. It's as though each one of us was some kind of crazy banana republic with a mad dictator who was making up their own rules. And if you think about it, it's a bizarre understanding of human relationships, isn't it? Because what it means is that human relationships are a sort of international treaty. You know, we're all our own sovereign states, and then we engage in some kind of international communications, and we enter into contracts and treaties and so on when we develop relationships. But ultimately, we're all atomized individuals making our own laws, choosing. Now, that is the idea of autonomy, really, which is very powerful in modern medical ethics, as you well know, and which is not all bad. The idea that we should take responsibility, that we should be able to exercise freedom and so on, there's lots of positive things in that, but I would suggest it's a fundamentally flawed understanding of what it means to be human. It's a very warped and individualistic understanding. And this right of autonomy then really taps into control over my death. So many people, like Terry Pratchett, said, I believe passionately that any individual should have the right to choose, as far as it is possible, the time and the conditions of their death. In other words, to people like Terry Pratchett, it seems utterly bizarre that you can control every other aspect of your life, but the one thing you cannot control is the time and the means by which you're going to die. And they think that is ridiculous. This is the 21st century, for goodness sake. Why on earth, if you can control every other aspect of your life, why can you not control how you die and when you die? It's just a matter of choice and control and autonomy. It's interesting that when you go stepping back a bit and just looking at the public debate that goes on about this, it's very interesting to see the language that is used about the process. And what you find is all these kind of vague and euphemistic terms. So ensuring a dignified death, the right to die, the right to choose, easing the passing, assisted dying. That's a particular bête noire of mine. But that, of course, that is the phrase which was chosen for the bill both in the House of Lords and in the House of Commons. And it was a phrase which was chosen by highly sophisticated and educated lawyers and legislators who spend their whole life in the precise and forensic use of language. And they deliberately chose a vague, euphemistic and misleading phrase. Dying, by definition, is a passive thing. It's something that happens passively, whereas killing or suicide are active acts. And yet they use this phrase, assisted dying, of suicide, of assisted suicide. And of course it was a deliberately euphemistic and I think misleading phrase. So choosing to die, easeful death, ending suffering when it becomes unbearable, all that. Why is it all of those phrases are referring either to a form of homicide, intentional killing, or to a form of suicide? Both of which are very clear words in the English language. Why is it that those words don't appear in the public debate? And I think it's pretty obvious that if you put those words in, it would cause concern, and therefore so often it seems that euphemistic language is, and often misleading language is used. So I like this proverb that says, the beginning of wisdom is to call things by their proper name. And I think if we're talking about some various forms of medical killing, we do need to be precise about what we're talking about. So a common definition would be this, that euthanasia is intentional medical killing. Of course, euthanasia literally means good death, euthanatos. And it's another example. It was actually introduced in the 19th century as another euphemism for killing. But what it actually means is intentional medical killing of a person whose life is thought not to be worth living. So the point is, the intention is to kill, and the intention is to introduce death into somebody who is not actively dying. And assisted suicide is a very closely related phenomenon. Here, the intention of the doctor is the same. The intention of the doctor is that the patient will die as rapidly and as cleanly as possible. And the doctor facilitates, advises, calculates the lethal dose, makes sure that the medicine is available, advises how to take the lethal dose, for instance, that you have to sit upright, that you have to take an antiemetic, that you have to make sure that you don't vomit, that these are all the various techniques to try and ensure that it works as rapidly and clinically as possible. If necessary, the doctor is prepared to put in a cannula and hook up a syringe with the medication all available, and even a computerized device so that it can be administered. But the doctor says, I will not do the final act. I will hold back. In the end, you have to press the button. You have to swallow the liquids. I'm not being involved. So I would argue that from a moral point of view, the difference between actually pressing the button and that taking all the steps in terms of intending to kill, and calculating the lethal dose and all the rest, morally there's very little difference between the two. Interestingly, in continental Europe, it's euthanasia which is seen as the primary means for medical killing, and the doctor does the act. And Whereas in the Anglo-Saxon world, in Britain and in the States, because they have much greater emphasis on autonomy, they've come to the conclusion that assisted suicide seems much more acceptable than the doctor actually doing the deed, and that's why the move has been towards legalising assisted suicide. In private, the pro-euthanasia campaigners are quite clear that this is just the first step in the door, and that once assisted suicide becomes accepted, then the next step would be able to see that under certain cases that the active medical killing would be the next step. Now, I think a very important point, which doesn't get enough emphasis, is that the intention of the doctor is revealed by the choice of drugs. So when the euthanasia doctors first started trying to kill people, they didn't know how to do it. It wasn't the sort of thing you generally got taught at medical school. And so they started experimenting, and there was a sort of various grisly period when they tried injecting massive doses of insulin, they tried injecting air into people's veins, doing all kinds of things, of finding a nice clean way of killing people. Well, they've eventually worked out how you do it, and basically you use an absolutely massive dose of barbiturates, usually between 50 and 100 times the therapeutic dose. And when it's given intravenously, you usually combine it with a muscle relaxant as well. So, you get this massive dose of barbiturates combined with a muscle relaxant, and bang, surprise, surprise, the patient then dies on the end of the needle, rapidly, quickly, and cleanly. When you're using assisted suicide, they do the same. So it's usually 100 times the dose of barbiturate as an oral preparation, and it's usually preceded by an antiemetic, and they take, as I said, steps to try and make sure that people don't vomit and aspirate and so on, although unfortunately that does sometimes happen. Now, the point is that those drugs have no place at all in palliative care. In palliative care, people never use massive dose of barbiturates. Why not? Answer: because barbiturates are dangerous and kill people. So what drugs do people use in palliative care? Answer: they use benzodiazepines and they use opiates. And the reason they use benzodiazepines is that they are incredibly safe. You can take a massive overdose of benzodiazepines and you go to sleep for 2 or 3 days and you wake up. So, and that's because palliative care doctors are not trying to kill people. They're trying to provide best possible care at the end of life. So in other words, this story that actually doctors are bumping people off all the time and all we're trying to do is regularize it and legalize it is a complete falsehood, because the intention of the act is revealed by the choice of drugs, and the drugs that the euthanasia doctors use are the drugs of the anaesthetist, of massive doses of barbiturates and muscle relaxants and sometimes cardioplegics to actually stop the heart. And they're not at all the drugs of palliative care doctors. So euthanasia is not the same as withdrawing medical treatment which is futile or burdensome, or where the patient is actively dying. This is good medical care. So here, this is really about a very important concept in all clinical medicine of balancing the benefits and burdens of medical care. And if the medical treatment that we're giving has excessive burdens relative to its benefits, then we should stop giving the treatment. And so withdrawing burdensome medical treatment is not the same as intending to kill. And in fact, carrying on giving futile and burdensome treatment is a form of abuse. Unfortunately, it's something that happens a lot in the modern NHS, but it's something that we should try and stand against and try to minimise, because unnecessary and burdensome treatment is a form of abuse. So withdrawing futile and burdensome treatment is not the same as euthanasia. And similarly, euthanasia is not the same as giving a painkilling or other treatment in order to benefit the patient, which may have the unintended side effect of shortening life. And that's the principle of double effect. which is fundamentally recognizing the difference between intention and foresight. So there's a difference between what I'm intending to do and what I foresee might happen as a result of my treatment. And actually, if you think about it, that is a very fundamental thing in all medical treatment. I spent some time as a junior doctor working in oncology in Bart's Hospital, and I remember injecting these horrific oncological drugs, chemotherapeutic agents, into people's veins. And I knew perfectly well what the risks of these agents were. I knew that they rotted your bone marrow and they damaged the heart muscle and they meant that you were going to get candida infections and all the rest, and your hair was going to fall out. And I knew that there was a significant risk that the patient would die as a result of the medication I was injecting into their veins. So what kind of sort of murdering, homicidal maniac was I that I was going injecting these drugs into people's veins? Well, actually, the intention was to cure the cancer, but I could foresee what the side effects were. Now, of course, it would be possible to use those same kind of drugs to murder people. I mean, it's the sort of plot for a sort of schlock medical horror novel, wouldn't it? Where there's some murderer out loose in the oncology department going around killing people with chemotherapeutic agents. But we immediately recognize that's different because there the intention is to kill. So this distinction between intention and foresight is in fact it's something intuitively we all get. And it's a very important distinction. And so we know that the opiates are the most powerful pain relievers we have. We know that they may cause respiratory depression. And therefore we know that in certain patients it's possible that they will have this unintended side effect of shortening life. If you had another agent which didn't cause respiratory depression but which was just as good as a painkiller, you would use that. But since we don't, and my intention is to treat the pain, I recognise the possibility that I might shorten life. Now, apparently, what palliative care doctors say is that when opiates are used with expertise, all the evidence is, in fact, if anything, they extend life and not shorten it. And that's because they have such good pain-relieving effect that they often restore the will to live, and people feel they actually want to carry on living, and so it's misleading to think that opiates actually generally shorten people's lives. They don't if they're used with skill and precision. So the assisted dying bill, so-called, was defeated by a large majority in the House of Commons last year. And it's interesting that in the debates that went on, particularly in the House of Commons, it was very often it was the success of palliative care and the impact of palliative care, which was used as an argument against the need to legislate for some kind of physician-assisted suicide. Just stepping back and thinking a bit about suicide itself, of course, in many cultures of the past, suicide was seen as a very honourable and noble way to die. So in ancient Japanese culture, in the Stoics, in many of the Norse gods, suicide was seen as a very noble and honourable way to die. But it is very interesting that in all cultures influenced by Christianity, and in the major Western ethical traditions, suicide has never been seen as a noble or honourable way to die. It's always been seen as an act of despair, as an act of hopelessness. And if you think, for instance, of the suicide pilots in the Japanese, it would be impossible to imagine the RAF sort of sending an assault of suicide pilots, or sending suicide bombers into Syria in order to try and wipe out ISIS. It isn't something that fits within the Western tradition. So self-destruction is seen not as a right, but it's actually a harm to be avoided. And of course, as we all know, suicide prevention is something that is seen as a very important part of healthcare practice, something that all medical students and junior doctors are trained on about recognising suicide risk and taking steps to minimise suicide risk. So suicide prevention is seen as an extremely important part of health service practice. So it's rather bizarre that you had other people saying, well, actually, we need to rehabilitate suicide and make this something that's seen as actually a responsible and noble way to die. So Cicely Saunders was a remarkable lady who had a vision of a better way of caring for dying people. And she worked in London at various religious hospices, and then she developed considerable expertise in the use of opiates. She used the very best pharmacological information. She did detailed studies of patients under her care, and she came up with a way of caring for dying people which was extraordinarily effective. And these are some of the quotes. "You matter because you are you, and you matter to the end of your life. Not only will we help you to die well, we'll help you to live before you die." And in fact, that phrase, "to live before you die," became one of the slogans of the movement. In other words, it wasn't all about helping people to die. What Cicely Saunders and the other pioneers recognised is that the last few hours, days and weeks of life could actually be the most astonishingly rich and profound and meaningful experience, that with the right kind of support, people could live in a very rich and profound way. It wasn't about just helping them, bumping them off as rapidly as possible. And one of her other slogans was, "You don't have to kill the patient in order to kill the pain." It's interesting that euthanasia started in Holland basically because doctors were confronted with people who were crying out in agony, and the doctors felt completely powerless. And the only way they could stop the pain was to kill them, to kill the patient. And they claimed the legal doctrine of necessity. They had no choice but to kill the patient because the patient was in agony. And it's interesting that the same thing didn't happen in the UK, and arguably it didn't happen because of Cicely Saunders and the pioneers of palliative care, who demonstrated that you don't have to kill the patient in order to kill the pain. And some years ago, I happened to be sitting at a dinner in the Houses of Commons, in the House of Parliament, and was sitting next door to me was a chap who was a very distinguished medical lord. And I knew that he'd been involved in debates about euthanasia in the 1990s, and in particular that he'd been quite in favour of the legalisation of euthanasia. And yet the committee that he was leading eventually changed their mind and argued strongly against the legalisation of euthanasia in the UK. And I thought this was too good an opportunity, and I turned to him and I said, was it true that when you went and visited Holland that you were really so appalled by what you saw, that had a negative effect on the youth legislation here? And he said, yes, it was quite true. We were really quite shocked by what we saw in Holland. And I said, why do you think it never happened here? Why is euthanasia never legalised? He said, oh, that's very simple. Two words, Cicely Saunders. So it's interesting that, I got it from the horse's mouth, that the impact of this one lady on a whole national, and in fact international, because people used to come to learn from her and from her team about the care of the dying. So Robert Twycross, who worked with Cicely Saunders, said, "Palliative care developed as a response to the statement, 'There is nothing more than we can do.' This is never true. There is always more than we can do." So when some pompous consultant leans across the desk to you and says, "There is nothing more that we can do," quote the words of Robert Twycross back at him or her. This is never true. There is always more than we can do. So palliative care is indicated when it is agreed that active medical treatment is not appropriate and death is thought to be likely within weeks or months. And the goal is to provide skilled multidisciplinary care to minimise all forms of pain and distress and maximise the experiences and opportunities of the time remaining. And so what you're trying to do in palliative care is neither to accelerate the dying process, to try and bump the patient off as rapidly as possible, nor are you trying to keep the patient alive as long as possible. The theory is that you allow death to occur by natural processes while you focus on making the most of whatever time is left by maximising the patient's experience. And what many people caring for the dying have found, including Cicely Saunders, is that dying well is actually an opportunity. It's an opportunity for reordering priorities. When people are often confronted by the knowledge that they're dying within days or weeks, all of a sudden their priorities change. What really matters to them changes, and they are able then to focus on the things that are most important. It's an opportunity for restoring broken relationships, for saying goodbye, for fulfilling dreams. Sometimes, this thing that I've always longed to do and I've never been able to admit it. Now, I've only got a month left. This is the thing I really want to do. And so I can actually start to fulfill my dreams. Finding new meaning and preparing to meet God. One of Cicely Saunders' great insights was that pain that people were suffering was not just physical pain. So yes, there is physical pain. Here's somebody dying of cancer and the metastases are pressing on the bone and causing inflammation and pain signals. There is physical pain, but there's also psychological pain. They're feeling anxious and depressed, and they're worrying about what the future will hold. So there's all this mental and psychological stuff going on. And then there's relational pain. They're worried about the impact of their impending death on their family, or perhaps the fact that they hadn't spoken to their son for 20 years, and the last time they spoke, there was this ferocious argument, and the son walked out, and now they're never going to have a chance to be reconciled with their son. And there's spiritual or existential pain. People are worrying about maybe feeling guilty about things from the past, or worrying about what the future is going to hold, worrying if there's anything after death. And what Cicely Saunders said is that you have to deal with all four kinds of pain. You have to engage with the physical pain, and that will involve whatever it takes in terms of physical remedies and necessary sectioning nerves, or finding other ways of addressing the physical pain. But there's also psychological pain, which may mean talking therapies and counselling. There's relational pain. So what you do is you track down the son and you say, your father is dying, will you come and be reconciled to him? And spiritual pain. Cicely Saunders arranged St Christopher's Hospice so that the chapel was in the centre of the building, and that from every clinical area the beds could be pushed directly into the chapel. However sick people were, they could still be pushed into the chapel, and there was a regular cycle of services and so on. So she put spiritual care at the centre of the care of the patients as well. And another of the quotes is that suffering is not a question which demands an answer. It's not a problem which demands a solution. It's a mystery which demands a presence. So yes, you cannot remove all the suffering. You cannot remove all the pain. You cannot sanitize what is sometimes a desperately difficult and challenging period. But what you can do is you can be the presence. You can be there. What people fear most as they approach death is they fear abandonment. They fear being abandoned and left. And what Cicely Saunders said is that we will be there for you right to the end. I'm coming to the end, but just very briefly, it's interesting how palliative care is developing and meeting new challenges. So palliative care started really dealing with cancer patients. But increasingly now, it's facing new challenges with people with neurological conditions like motor neurone disease, with chronic obstructive airways disease, chronic cardiac failure, and so on. And these are bringing new challenges and difficulties. And one of the really challenging things are patients who are on continuous ventilation, often home ventilation, and who then make a decision that they've had enough and they want to die, and they choose the point at which they're going to stop the ventilation. And psychologically, it feels very much like a suicide, because they are the ones who are deciding the point at which they're going to die. Now, arguably, it isn't the same as suicide, because it is the technology that is keeping them alive. and you are withdrawing treatment rather than introducing death. And they've got a lethal condition, and the technology is keeping it at bay. But psychologically, I think a lot of staff find this extremely distressing and painful to be involved with. So I think these are some of the challenges which palliative care is meeting. And I don't have an easy answer for these kind of problems, but I think it shows that there are, significant new challenges for the future. The government is very keen to have us involved in our own dying process, and the two options that they're promoting is, one, the idea that we should, each of us nominates another person with lasting power of attorney, so that they then have legal right to make medical decisions about our care if we become incapacitated. And this can be a spouse, it can be a friend, it can be a pastor, it can be a lawyer. But it's somebody who takes on responsibility, and someone who we would then share our own concerns and needs with. The second possibility is writing a so-called living will, an advanced decision to refuse treatment, where you say that if X happens, then I refuse to have the following treatments. And both of these options, I think, have some potential, but they often have problems and unforeseen consequences, and have created some real ethical difficulties. And just to illustrate the ethical difficulties, that this is a very troubling case. A lady called Kerry Wolterton, who had some kind of chronic psychiatric illness, and she'd repeatedly tried to kill herself by taking ethylene glycol antifreeze, and she'd had repeated resuscitations and had been brought back from the blink. And then she arrives in A&E, having again taken a big dose of ethylene glycol, but she's carrying an advanced directive in which, very carefully written, she says that she refuses to have any medical treatment, and that she didn't want to die alone, so she'd prefer to die in hospital, but she's refusing to give consent to any medical treatment. And this caused a real challenge for the doctors who were caring for her, but in the end they decided not to resuscitate her, not to treat her, and she died. And at the coroner's inquest, the coroner concluded that they had acted legally, that they had effectively done the right thing by allowing her to die. So the challenge is that when a living will, an advanced directive, is in fact suicidal, legally doctors can find themselves in a position where effectively they would be accused of assault if they intervened, if the living will is valid. So you can see the sort of challenges and problems this is likely to create for the future. And again, I don't have an easy answer to that one. What about the issue about dementia? I think dementia has become, for many people, the greatest fear. It's a greater fear than cancer. It's the fear of losing your mind, I think, for many people is the most terrifying thing. It's interesting, I think, from a Christian point of view, that the perspective on dementia is rather different, because the Christian understanding of our personhood is that that's something that is held by God, that whatever happens in the chances, the contingencies of life, whatever happens to my brain and my conscious experiences, my thought processes and my memory, my personhood is secure in the eternal knowledge and covenant love of God himself. So who I am, even when I've forgotten who I am, you, my friends, are there to remember and remind me. But also, ultimately, it is God who holds my identity secure. So that means, yes, we've got to provide the very best possible care. And again, these fourfold things: physical, psychological, relational, spiritual. I mean, what's interesting in people who care for dementia is they say that you often get levels of insight vary from hour to hour or day to day. And that in most people, you get little windows of insight when people suddenly seem to be very lucid and available. It sometimes only lasts for minutes, but it's a window when you can use that window to communicate with a person and communicate love and reassurance. So when I'm forgetting who I am, I need you to remind me who I am and what's important to me. And when I can't pray for myself, I need to know that you will pray for me. And I need you to reassure me that I'm safe and that you will always love me and that you won't abandon me. And as we know, hearing and touch are often the last senses to remain as people approach death, and there's always a place for loving, gentle words and a cuddle. So, yes, caring for people in these kind of profound states is not easy. It's demanding, it's challenging. But in the end, it seems to me it's a better way of caring rather than saying, I want to destroy this person's life. It's best that we help them to kill themselves. Just like in the rest of medical care, we have to balance the benefits and burdens of treatment when we're caring for demented people. We have to say, does this treatment, for instance, offering nasogastric feeds, other kind of treatments, are these bringing benefits greater than the burdens? Very often they aren't. The burdens of having nasogastric inclusion and assisted hydration is greater than the benefits, but it takes skill, and often there isn't a necessarily right answer about balancing benefits and burdens. I just close with, I think one of the things that Christian faith says is something completely different to this modern preoccupation with autonomy, and that is, it says that dependence is not an alien, subhuman, undignified condition. Actually, it's part of our humanity. It's part of the narrative of every human life. We come into this world utterly and totally dependent on the love and care of others. We go through a phase where other people care for us, where we care for other people, and then we end our life utterly dependent on the love and care of others. And this is not some kind of evil, terrible, outrageous phenomenon. Actually, it's part of the narrative. And bearing one another's burdens is part of the way that a community is called to care, that we care, we support one another. And as Paul said, bear one another's burdens, and in this way you will fulfill the law of Christ. And John Donne expressed it beautifully. His vision of a society was not one of autonomy, where everybody does their own thing, but it's in this vision, no man is an island entire of itself. Every man is a piece of the continent, a part of the main. If a clod be washed away by the sea, Europe is the less. Any man's death diminishes me because I'm involved in mankind. And therefore never send to know for whom the bell tolls. He's hearing the funeral bell tolling and he's saying, who is it for? But never send, it tolls for thee. So I close with these words of Joseph Piper. Love is a way of saying to another, it's good that you exist. It's good that you're in the world. The trouble with suicide and with euthanasia is it says it's bad that you exist. It'd be much better for the world if you didn't exist. It'd be much better for the world if we could get rid of you. But I would buy this. Love is a way of saying to another. Love never says it's bad that you exist. Love always says it's good that you exist. It's good that you're in the world.